Every patient has the legal right to make medical decisions for themselves. But what if you can't? When you can't speak for yourself, someone will do it for you. The only question is whether those decisions reflect your wishes or a doctor's assumptions. Patients and families don't lose control because they're wrong. They lose control because they don't know the rules. Understanding capacity gives them a way back into the conversation. So how does the doctor decide whether you are capable of making your own medical decisions? First of all, it's not entirely subjective. He or she has to evaluate 4 specific criteria. And secondly, this is done every time you have to make a decision, so it's not permanent. The first requirement for medical capacity is understanding. The patient must be able to take in the basic facts. What's happening? What's the diagnosis? What treatment is being recommended? They aren't expected to be a medical expert, but they do have to be able to grasp the essential information well enough to participate in the decision. If the patient can't repeat back the core facts in their own words or tell you what condition they're being treated for, then the first criterion for capacity is not met. Understanding is the foundation. Without it, nothing else matters. The second requirement is appreciation. This is where many capacity assessments fail. Not because the patient doesn't know the facts, but because they can't connect those facts to themselves. A patient might be able to say, yes, pneumonia can be serious, but still insist, but I'm not that sick. I don't need treatment. Appreciation asks, does the patient understand that the medical information applies to them right now in this moment? If delirium, confusion, trauma, or denial prevent that connection, the patient can't appreciate the consequences of their decision. The third requirement is reasoning. The patient doesn't have to agree with the doctor or do what he thinks is best, but you do have to be able to explain why you're choosing one option over another. The doctors are evaluating whether the patient can compare risks and benefits, explain their priorities, and articulate a consistent rationale. A patient might say, I don't want the surgery because I'm afraid of the pain, or I want the surgery because I want every chance to recover. Both are valid. Reasoning is about showing a coherent thought process. If the reasoning is absent, disorganized, or driven by hallucinations or confusion, then the third criterion is not met. The fourth requirement is the ability to communicate a stable choice. The patient must be able to express a decision, verbally, in writing, or through gestures, and that decision must stay consistent long enough to act on. If the patient says yes 1 minute and no the next, if they drift in and out of lucidity, if sedation, delirium, or pain prevent them from expressing a clear preference, then the fourth criterion is not met. Communication is the final step. Without it, even a fully reasoned decision can't be carried out. Here's what you need to know. Most of the time, capacity is determined through a quick bedside assessment, a brief conversation with a doctor who may be rushed or under pressure. But this is not the final word. The first and most important thing to keep in mind is that if you disagree with a bedside capacity call, you can request a formal evaluation. This usually involves a specialty consult, such as psych or neurology or geriatrics. Sometimes it's a multidisciplinary team effort, and it depends on the underlying medical issues. The process involves cognitive testing and probably memory and attention evaluations. This can take some time, and it's one reason why a capacity determination is temporary. A patient coming out of anesthesia may lack capacity at 9 a.m., but be fully capable at 2 p.m. That's why capacity is a snapshot, not a label. In the temporary moment, the surrogate will be asked to make any urgent medical decisions until the patient recovers or a final determination is made. That's why it's absolutely essential that a patient have the hard conversations with their surrogate and family members when they still can. If you don't, the medical team will make them for you. Another thing to remember is that if there is a dispute that can't be resolved, it should trigger an ethics consultation. If it doesn't, you can ask for one through the attending physician or the patient advocate. Every hospital has an ethics committee. and it is accessible to families. People sometimes confuse decision-making capacity with competence, but they are not the same thing. Capacity is medical, and competence is a legal decision that can only be made by a judge. Obviously, the judge will rely on medical opinion, but if there's a dispute, the court can and will order an independent opinion. The hospital, the VA, and the medical team can't label a patient incompetent without a court order. And that scenario is not easily reversed. So it's typically reserved for patients who have permanent and long-term impairments like dementia. Here's the take-home point. Capacity affects a single medical decision. Competence affects a person's entire legal rights. And capacity isn't just situational. It's also temporary, fluctuating, and medically reversible. And for surrogates, if your loved one seems to be making choices you know they would never make if they were well, speak up. No doctor knows a patient better than the people who interact with them every day. A brief bedside assessment can be deceptive, even for experienced clinicians. Delirium, pain, fear, medication effects, or exhaustion can all distort how a patient presents in the moment. If something feels off, trust your instincts and say so. Sometimes challenging the medical team is necessary. You're providing context they can't get from a 5-minute conversation. Your insight is part of the capacity evaluation, and it matters. If your concerns get dismissed, or if the bedside assessment doesn't match what you know about your loved one, request a formal capacity evaluation or even an ethics consult. You're not being difficult. You're protecting the patient's rights. Thanks for listening. I hope you found this information useful. Please feel free to leave comments or ask any questions you might have, and follow Second Watch for more information that can help you better advocate for yourself and your loved ones when being treated by the VHA.